It is my great pleasure to introduce our next speaker, Dr. Alex Kuroglian. If you have ever experienced discrimination at the hands of a healthcare professional, you may have thought, if only that provider had better training. Dr. Alex Kuroglian, MD, MPH, is one of the people leading the charge to develop better practices by changing and training the next generations of physicians. As Associate Professor of Psychiatry at Harvard Medical School and co-director of the Harvard Medical School Sexual and Gender Minority Health Equity Initiative, they are designing and integrating sexual and gender minority health education components for Harvard Medical School's curriculum, as well as other medical schools and health systems in New England and beyond. Dr. Kuroglian established the Massachusetts General Hospital Psychiatry Gender Identity Program and is clerkship director for the fourth-year elective in sexual and gender minority health at Harvard Medical School. In addition to their clinical education, he directs the National LGBTQIA+ Health Education Center at the Fenway Institute and mentors more junior researchers, helping to grow the field. We are so pleased to be presenting you today with Dr. Alex Kuroglian. Please welcome him.
Hi there. Nice to be with you all. You can hear me? Looks like you can. I'm getting some waving. Excellent. Well, pleasure to be joining you. Many thanks to the organizers of the conference for this wonderful event. I see some names already that I know from my days going off the deep end doing borderline personality disorder work at McLean Hospital as an MGH McLean psychiatry resident. So it's wonderful to be back in this world that I have such fond memories of working in, and that's informed all the work that I do in the area of LGBTQI+ health. I was asked to speak with you all today about how we can distinguish and address gender minority stress, which we'll talk about quite a bit, and borderline personality symptoms. And hopefully through this presentation, it'll become clear why this is such a relevant topic, one that comes up often and has some profound implications for patient care. We'll explain what gender minority stress is and its relationship to mental health disparities and inequities experienced by transgender and gender diverse communities. We'll apply a gender minority stress framework when considering borderline personality symptoms among transgender and gender diverse people. And we'll talk about how to tailor evidence-based interventions for borderline personality disorder based on a gender minority stress framework. A word about our education center. One of my hats is to direct the National LGBTQI+ Health Education Center at the Fenway Institute in Boston. This is funded by the U.S. Bureau of Primary Health Care to implement evidence-informed interventions and provide education, training, technical assistance, and implementation science focused on health programs and systems for LGBTQI+ communities. We do work in all 50 states, in DC and Puerto Rico, and increasingly around the world, in Uganda, Jamaica, India, South Korea, Poland, Switzerland, and elsewhere. Please feel free to check out our resources on our website. We have many webinars by national leaders in this area that are then recorded and available for free on our website and available for continuing education credits. Over 80 best practice guidelines and briefs, including this one on how to create a transgender health program within your organization. We have interactive learning modules, recordings from our Harvard Medical School continuing education conferences on advancing excellence in transgender health, and many more. So feel free to check it out, all available for free and easy to access. Much of what I'm going to present today, we articulated in a paper in the Harvard Review of Psychiatry in 2019, which is shown here on distinguishing and addressing gender minority stress and borderline personality symptoms. When I don't make an attribution to a particular reference, when I don't provide a citation, what I'm presenting can be found in an expanded upon way in this article. As many of you are probably aware, there's increasing visibility in clinical settings for transgender and gender diverse people seeking mental health care or seeking referrals for medical and surgical interventions to affirm their gender identity. Doing the work that we do around the country, education, training, and technical assistance, we encounter many clinicians and care teams who express hesitation to deliver or offer referrals for gender affirming care. And they often tell us that they wonder whether a patient's stated transgender or gender diverse identity is caused by some kind of unstable self-image in the context of identity diffusion, say in the setting of borderline personality disorder. And there's a paucity of research on diagnosing and treating borderline personality disorder among transgender or gender diverse people, or as we say, gender minority folks, and a lack of guidelines for mental health clinicians who generally are seeking to learn more and make informed and compassionate recommendations for patients or provide informed and compassionate care themselves. I'm going to start by explaining how we conceptualize gender diversity, which is certainly something I didn't have in an adequate sense in my medical school training as a psychiatry resident. It's really when I got over to Fenway Health in Boston, a historically LGBTQI plus health center, and started caring for a very high volume of transgender and gender diverse patients that I learned this on the job. And we're trying to change that. Certainly at our medical school, we're 3 years into a sexual and gender minority health equity initiative to reform and develop this within our medical education system. It's not part of the standard curriculum for physicians, for psychologists, for social workers, for nurses. So we do need to improve that. And for the time being, what we have is the kind of continuing education that I mentioned that we offer through our center. So starting from scratch here, not making assumptions about where folks in today's event are at. When babies are born in most countries and cultures around the world, they're typically assigned one of two sexes based on physical sex characteristics, female or male. In some cases, intersex if they have characteristics of sex development, variations in sex development that don't fit traditional binary notions of female or male bodies. We now know that these babies grow up, become children, adolescents, and adults who may have a gender identity, a core fundamental inner sense of their gender that does not align with society's expectations based on the sex they were assigned when they were born. So what is gender identity? It's a person's inner sense of being a girl, woman, boy, man, something beyond girl, boy, or woman, man, or having no gender at all. All people have a gender identity, and we also appreciate that many people have a gender identity that doesn't fit one of society's two traditional categories of either being a girl or being a boy, either being a woman or being a man. So we increasingly acknowledge that many people have what we would refer to as a non-binary gender identity. And if you look at the US Trans Survey of 28,000 folks nationally, 35% endorsed having a non-binary gender identity. And as we look at younger and younger cohorts in the US, increasingly, more and more people are comfortable identifying in this way, which reflects a natural diversity in gender that exists among humans. It's not a binary construct the same way height isn't a binary construct, skin color isn't a binary trait among humans, and so on. That's gender identity. Gender expression is how a person expresses or communicates their gender to other people. This may be through your mannerisms, the way you walk, your voice, the way you dress, your hairstyle. And gender expression is also quite complex. It's not necessarily the case that people assigned female sex at birth would want to or ought to express their gender in a traditionally feminine way, whatever that means. And it's not necessarily the case that people assigned male sex at birth would want to or ought to express their gender in a traditionally masculine way, whatever that means. Gender expression is also contextual. Someone may have a more feminine gender expression at work and a more masculine gender expression at home, for example. It's cultural. What's considered feminine or masculine in one culture is not necessarily the same in another culture. And the reality is each of us has aspects of our gender expression that society would consider both traditionally feminine with regard to some traits and traditionally masculine with regard to some other traits. So we all have both of these within us and in how we express our gender at different times. What does the term transgender mean? It's an umbrella term for people who have a gender identity that doesn't fit society's expectations based on the sex they were assigned when they were born. In terms of binary gender identities, if someone was assigned male sex at birth and identifies as a woman, they may refer themselves as a transgender woman, as a trans woman, simply as a woman. Someone assigned female sex at birth who identifies as a man may refer themselves as a transgender man, as a trans man, simply as a man. And non-binary people may refer themselves as non-binary, may refer themselves as genderqueer, may refer themselves as gender fluid, which implies a gender identity that's more dynamic and potentially going to evolve over time. This has implications when we think about distinguishing and addressing gender minority stress and borderline personality symptoms, as we'll get to in a moment. We also use the terms transfeminine and transmasculine that are inclusive of people with both binary and non-binary gender identities. A transfeminine person is someone assigned male sex at birth who identifies more with femininity than with masculinity. They may identify in a traditional binary way as a woman. They may also not. And transgender and gender diverse people in many cases will undergo a gender affirmation. We used to refer to this more as a gender transition. We tend to use the term affirmation more because it emphasizes the current affirmed gender identity rather than the sex of the person was assigned at birth, which trans and gender diverse people typically by and large do not want emphasized. And this is the process of changing from living and being perceived as a gender society typically associates with the sex you were assigned when you were born, to living and being perceived the way you understand yourself. And this includes psychological affirmation, coming to terms with and understanding your own gender identity, social affirmation, which can include changing your name, changing your pronouns, changing your gender marker on government-issued documentation, changing the way you dress. Part of that is legal affirmation or document change in terms of gender markers. And then there's medical affirmation, which includes gender-affirming hormone therapy. That can include pubertal suppressant medication in 10 or stage 2 of puberty, gonadotropin-releasing hormone analogs like Lupron, and then initiating either testosterone or estradiol for secondary sex characteristics subsequently. And people even who don't receive pubertal suppression in puberty at any stage in adolescence or adulthood can initiate gender-affirming hormone therapy with either testosterone or estradiol. And then there's gender-affirming surgical care. And there are a range of gender-affirming surgical procedures. Not every transgender and gender diverse person necessarily wants these various forms of affirmation. Not everybody legally changes their name, for example, or their government-issued documentation. Not everybody pursues gender-affirming hormone therapy. Not everybody pursues gender-affirming surgery or all the possible types of gender-affirming surgery for their gender identity. A word about sexual orientation, just because the two are often conflated. Gender identity and sexual orientation are two different concepts, two different experiences. Everyone has both a sexual orientation and a gender identity. Each of us participating today in this session have one of each. Sexual orientation is how a person identifies their physical, emotional, and romantic attachments to other people with regard to gender. We think about this in three components. There's desire. This is whom someone is attracted to. When I was in med school, I was trained to ask, are you attracted to women, men, or both? We've moved beyond that. Now we ask, do you have attractions to other people, to make room for asexual and aromantic people? The person says yes, then we would ask, who are you attracted to generally, or what are the genders of the people you're attracted to acknowledge that there are more than two possible genders. Then there's behavior. This is whom someone is engaging in intimate or sexual activity with and what type of intimate or sexual activity. Then there's sexual orientation identity, and this refers to the range of labels and communities that exist in society that a person may or may not affiliate with regarding their sexual orientation. Some of the more common ones include straight, gay, lesbian, bisexual, queer, asexual, pansexual. We have a glossary of terms on our website you can check out at lgbtqiahealtheducation.org with regard to gender identity, gender expression, sex development, and sexual orientation. Transgender and gender diverse people may have the full range of sexual orientations. You can't predict somebody's sexual orientation based on the fact that they're, say, a transgender woman or a transgender man. That was a lot pretty quickly. I appreciate that and apologize for it. I think it'll be helpful context as we move forward. Historically, there is documentation throughout countries, civilizations, eras in history of people living as a gender not expected based on their society with regard to their sex assigned at birth. So this is a common experience and a common historical phenomenon across civilizations and across time of gender diversity with regard to sex assigned at birth. In the mid-20th century, the American medical community started paying closer attention to gender diversity. And with few exceptions, psychiatrists and other medical experts regarded transsexuals, as people were referred to at the time, as by and large mentally ill, delusional, or sexually deviant. In 1980, the DSM-3 added a diagnosis of transsexualism, categorizing it under psychosexual disorders and describing it as generally being a form of moderate to severe coexisting personality disturbance. DSM-3 added uncertainty of gender identity as an example of identity disturbance among people with borderline personality disorder. And much of the literature in this area in the 1980s discussed gender minority identities as a possible subtype of borderline personality disorder or other personality disorders. Although in DSM-4R, there was no longer a gender identity reference under borderline personality disorder diagnosis, this version of the DSM used the terminology of gender identity disorder and disturbance as diagnostic guidance for gender minorities. And this lent ongoing credence to the notion that gender diversity was inherently pathological. It wasn't until 2013 with the publication of DSM-5 that gender identity disorder was replaced with a diagnosis of gender dysphoria to move beyond implying that the identity itself is disordered in some way. And this label of gender dysphoria was chosen to emphasize the need to alleviate dysphoria through gender affirmation rather than to treat psychopathology. So this really opened the gates for a lot more access to gender-affirming medical and surgical care. Insurance companies started covering gender-affirming medical and surgical care. The Affordable Care Act had a provision to prohibit discrimination based on gender identity as a pre-existing condition. In Massachusetts, Rhine-based, in 2014, right after this, Deval Pastrick, our governor at the time, signed into law prohibition of exclusion from insurance coverage for gender-affirming hormone therapy and surgery. The American Medical Association since 2008 had declared gender-affirming medical and surgical care medically necessary treatment for transgender and gender diverse people. And despite this shift towards a more affirming approach for gender minorities, many people still believe that any inclusion of a gender identity-related diagnosis in the DSM will prime clinicians to view gender minorities as mentally ill or to view this as a form of psychopathology in some way. This is the gender dysphoria diagnosis in the DSM. It basically refers to a marked incongruence between one's experienced or expressed gender and assigned gender of at least 6 months duration, associated with clinically significant distress or impairment in social and occupational functioning. There are different diagnoses, slightly for children and adolescents than there are for adults. Again, this is very controversial, having any diagnosis in the DSM related to an oppressed minority population. We published this piece in June of last year in the British Journal of Psychiatry on envisioning a future for transgender and gender diverse people beyond the DSM. So there's a big push among community advocates to uncouple gender diversity from the inherent stigma of any diagnostic classification in the DSM. There's a close look being taken at non-diagnosis codes like C codes in ICD-10 and Q codes in ICD-11 that factor influencing status and still reimbursement by third-party payers for care. I have time in my week where I see patients who don't need to see me for longitudinal psychiatric care, but need an evaluation for gender-affirming surgery from a doctoral level mental health clinician. I have to say, patient meets diagnostic criteria for gender dysphoria each time. Couldn't I potentially seek reimbursement without a diagnosis for something like psychiatric evaluation preceding gender-affirming surgical intervention? And this wouldn't have an assumption of distress or psychopathology associated with it. There are many people for whom gender-affirming hormone therapy and surgery are clearly indicated and beneficial. These people aren't necessarily walking around with some kind of crippling distress, the way that we conventionally think about gender dysphoria. In terms of prevalence of borderline personality disorder among transgender and gender diverse people, the literature reports a wide variability in prevalence of BPD and other personality disorders among trans and gender diverse folks. It ranges from 1% to 33%, with all but one of those studies reporting a prevalence of 7% or less. These used very wide-ranging terminology to describe transgender and gender diverse people. There are 2 other studies that reported a prevalence of 8% in one case and 23% in another case of access to cluster B personality disorders among transgender and gender diverse people. Studies that measured all personality disorders reported a range of BPD of 2% to 81%, so wildly variable, with highly inconsistent findings that aren't surprising if you think about it, given the methodological variability across these studies, studies using very different eligibility criteria, For example, clients diagnosed with gender identity disorder seeking surgery at gender identity clinics in one case, in another case, outpatient clients in different stages of gender affirmation, in another case, doing a study with the general population recruited from, and variability in the measures used to assess gender minority identity or status and psychiatric morbidity. DSM diagnostic definitions for transgender and gender diverse people also fluctuated over the years. So these studies were done at different points where maybe this was being defined differently in the DSM. And studies were conducted in different countries, Iran, Italy, Serbia, Sweden, United States, with different cultural norms regarding gender diversity. And contradictory findings may have arisen in part as a result of selection bias and limitations in the study designs. All were cross-sectional. Many had sample sizes of less than 100 participants. So due to this variability in findings, the small sample sizes, diversity of settings in which the studies were conducted, lack of longitudinal data, and other limitations in the literature, it's really difficult to know what the prevalence of borderline personality disorder is among transgender and gender diverse people. The authors of these studies pretty consistently concluded that psychiatric morbidity among trans and gender diverse people doesn't indicate that a gender minority identity is disordered or is an outcome of psychiatric illness. Instead, the authors concluded that psychiatric problems among transgender and gender diverse people may develop, among other possibilities, as a result of challenges of living as a stigmatized minority in a discriminatory environment. Now, increasingly in clinical care and research and policy work focused on transgender and gender diverse populations, we refer to what's known as a minority stress framework or a gender minority stress framework. The idea here is that transgender and gender diverse people from early childhood, developmentally through adolescence and early adulthood, older adulthood, experience everyday discrimination, victimization, microaggressions, frank violence, unfortunately, at a much higher prevalence than the general population. The FBI has reported in recent years that the population that experiences the highest incidence of hate crimes in the US is African American transgender women. So this is the horrific reality that many people are living with. And we think of all of this as external stigma-related stress. External stigma-related stress over time can lead for people to disruptions in certain general psychological processes like coping skills, emotional regulation, interpersonal functioning, having certain cognitive structures that may be protective in the moment and understandable given these developmental experiences, but are actually perpetuating distress, like believing it's never going to get better, nobody can be trusted, no one will ever love me. And all this external stigma-related stress can lead to internal stigma-related stress, internalized transphobia, expecting rejection, believing all the negative things that society has to say about your gender identity or expression, and identity concealment for fear of being mistreated or abused. All this external and internal stigma-related stress, we think, is related to what we see in the literature among transgender and gender diverse people, which is a higher prevalence of various behavioral health problems, depressive disorders, anxiety disorders, post-traumatic stress disorder, in some cases substance use disorders, apparently as a way to cope with all this stigma-related stress. Decreased self-care, decreased engagement in mental health care and in primary medical care, and down the road a much higher prevalence of various physical health problems as well. Data from the US Trans Survey of 28,000 people from every state in the US, including from Connecticut, showed that over 10% reported a family member was violent towards them because they were transgender, 8% were kicked out of the house because of their gender identity. Many experienced serious mistreatment in school, like verbal harassment, physical attacks, sexual assault because of their gender identity, and 17% experienced such severe mistreatment that they had to leave high school because of it before graduating. Transgender and gender diverse people also report much higher prevalence of poverty compared to the general population, much higher unemployment, much lower home ownership, and much higher likelihood of experiencing homelessness in the past year and across the lifetime. This is a paper we published in the American Journal of Public Health out of the US Trans Survey, looking at psychological attempts to change a person's gender identity from transgender to cisgender. And this is referred to in popular parlance as conversion therapy. We intentionally don't call it therapy because that implies it's a legitimate clinical practice, which it's not. In fact, it's quite harmful, as we'll see in a moment. And this is a heat map from the study showing prevalence of gender identity conversion efforts across the US, you can see that there are some geographic trends in terms of hotspots. And we did this partially because there's sort of advocacy and legal battle happening state by state to pass bans on conversion efforts for gender identity and sexual orientation. Less than half the states in the US have a ban on conversion efforts. Massachusetts just passed its ban in April of 2019 after several years. And what often happens is that the state house, for example, will pass a ban, and then the governor may say, well, we don't have conversion therapy in our state, so we don't need a ban, and veto it. That happened in Maine it was 2 years ago. The governor vetoed a ban on conversion efforts. So we published this to say, actually, conversion efforts do occur in every state and occur at high prevalence. We found that 14% of transgender and gender diverse people have been exposed to gender identity conversion efforts in their lifetime, which is approximately 188,000 transgender and gender diverse people in the US. If we look at the US Trans Survey, again, 39% of people report serious psychological distress in the past month compared to 5% of the general population. 40% of transgender and gender diverse people attempt suicide in their lifetime. That's higher than for any other minority population in the US. And that risk of attempting suicide decreases dramatically when people are able to access gender-affirming medical and surgical care. So it's important to think about gender-affirming care for transgender and gender diverse people as life-saving treatment. The risk of attempting suicide, or the lifetime prevalence of suicide attempts, is higher for gender minority adults than it is for presumed cisgender sexual minority adults like lesbian, gay, bisexual, queer people who are not transgender or gender diverse. And both of these are much higher than they are in the general population. This is a study we published last year in JAMA Psychiatry, again using the US Trans Survey, looking at the relationship between gender identity conversion efforts and suicide attempts. And just to, this isn't from our study, this is from the US Trans Survey, but 48% of respondents in the past year had suicidal ideation, 24% had a plan, 7% of the past year attempted suicide. And we can see that of the 40% who attempted suicide at some point in their life, 34% had their first attempt by age 13 and 92% by age 25. So those of you who work with trans and gender diverse children, adolescents, and adults are in a position to potentially really save lives and change someone's life trajectory. These are the findings from our study that I just mentioned. We found that lifetime exposure to gender identity conversion efforts was associated with more than twice the odds of attempting suicide in someone's life. Exposure to conversion efforts before age 10 was associated with more than 4 times the odds of attempting suicide in a person's lifetime. And interestingly, there was no difference in outcomes between conversion efforts by a religious advisor versus a secular type professional. Any effort to, so it's not the religious component that's dangerous, it's any effort to change someone's gender identity from transgender or gender diverse to cisgender. This study was then cited by the American Medical Association when they passed a resolution in support of a federal US ban on conversion efforts, and in June of last year by the United Nations General Assembly when they passed a resolution in support of an international ban on conversion efforts. Neither of those bans have happened yet. It's just, resolutions in support of them. Now, as I've mentioned, trans and gender diverse people experience chronic stigma-related stress, and the thinking is that this has manifestations that resemble symptoms of borderline personality disorder, whether people meet full diagnostic criteria for borderline personality disorder or not. And gender minority-related stress, manifestations of it, may explain why some of the studies that I mentioned earlier report a higher prevalence of borderline personality symptoms among trans and gender diverse people than what's known to be the case in the general population, and why clinicians sometimes may mistakenly formulate a patient as having borderline personality disorder when in fact, mechanistically, that's not what's going on. They're experiencing societal stigma, discrimination, and what we're seeing are manifestations of gender minority stress. Borderline personality disorder, as we know, is thought in part to develop in response to chronically invalidating early childhood environments or developmental environments. And childhood maltreatment is common generally among transgender and gender diverse children because of their gender identity or expression. And this may lead clinicians to think that transgender or gender diverse identity and borderline personality disorder have a common etiology. And it's important to note, while punishing a child continually for gender expansive behaviors could conceivably lead to disruptions in attachments later in life, childhood mistreatment is only one of several forms of stigma and abuse experienced by trans and gender diverse people. And this sort of pervasive societal stigma, discrimination, and abuse as a result of a person's transgender or gender diverse identity continues well into adulthood and throughout a person's lifespan. It's not restricted to that early developmental period. A word about self-injurious behavior. In addition to attachment challenges, as we know in BPD, there may be a high risk or high occurrence of suicide attempts, as well as non-suicidal self-injurious behavior. This was once thought to be basically pathognomonic for BPD. We now know that it's not necessarily the case. As many as 41% of transgender and gender diverse people, as I mentioned, have attempted suicide in their lifetime. Up to 53% report lifetime non-suicidal self-injurious behavior. This is often directed towards gender-identifying body parts and in the context of a body dysphoria among folks who haven't been affirmed in their gender identity yet and haven't accessed desired gender-affirming medical and surgical care. Suicidal behavior and non-suicidal self-injurious behavior among people with BPD may primarily be associated with impulsivity, low distress tolerance, co-occurring major depressive disorder, substance use disorder. Suicidal ideation and attempts in non-suicidal self-injury among trans and gender diverse people are thought to largely be responses to societal discrimination and rooted in experiences of gender dysphoria and gender minority stress. Rejection sensitivity is a characteristic of borderline personality disorder. It's also something we see often among transgender and gender diverse people who experience chronic gender minority stress and rejection as a result of their gender identities. We see this in qualitative research, for example, working with trans and gender diverse people. And over time, these experiences of rejection and rejection sensitivity, I was lucky to work and train under John Gunderson, who formulated borderline personality disorder this way, can adversely affect emotional regulation, coping skills, interpersonal functioning, cognitive processes. And all of these are categories of impairment similar to what's standard in borderline personality disorders. So we see this alignment between how we understand pathways within a gender minority stress framework for the disproportionate burden of behavioral health problems and physical health problems among trans and gender diverse people. Those mechanisms and pathways are a lot of how we think about and diagnose borderline personality disorder. And although stigma related to having a gender minority identity can produce this sort of rejection sensitivity and symptoms that may resemble or mimic borderline personality disorder, in many cases, we could conceptualize these as reasonable or even adaptive responses to the kind of pervasive societal stigma that trans and gender diverse folks experience, rather than kind of reflexively thinking of this as an underlying personality disorder. Sure. Okay, great, thank you. If we think about impulsivity, also a hallmark and diagnostic criterion for BPD, it's often interpreted as being present among trans and gender diverse people who may be viewed in some cases, particularly in the context of pervasive educational discrimination, employment discrimination, housing discrimination, as engaging in survival sex, for example, may be perceived as having high-risk sexual behaviors that are viewed as impulsive or interpreted as impulsive. And it's important for clinicians to make that attribution with caution, and only after considering the context of gender-related stigma and discrimination that trans and gender diverse folks experience. A study of 300 transgender adults in the US reported a significant association between engaging in sexual risk behaviors and expecting rejection and experiencing gender-related discrimination specifically. Qualitative studies with transgender women of color found that participants clearly distinguished engaging in high-risk sexual activity from impulsive behavior per se. And this sexual activity often occurred in the context of survival sex work, as I mentioned, after rejection by families of origin and discrimination in the workplace. And in many cases, having multiple male partners in the study was one of the ways in which people were able to affirm their gender identity as women. It can be very affirming to finally be accepted in your gender identity or gender expression in an intimate context with sexual partners, for example. So rather than kind of thinking of this as impulsivity the way we would conceptualize it traditionally in BPD, there are other gender minority stressors and drivers that may be at play. Clinicians may perceive these behaviors as impulsive. They can also, as mentioned before, be interpreted potentially as reasonable and well-planned survival or developmental behaviors within communities that are severely economically and socially marginalized. Important to note, and can't be overstated, the extent to which trans and gender diverse people experience barriers to accessing gender-affirming care. Trans and gender diverse communities have a long history of rejection when attempting to pursue physical and mental health care, both gender-affirming physical and mental health care, but even, say, primary medical care or mental health care in general, and being harassed within healthcare contexts or denied treatment because of their gender identity or expression. Or encountering clinicians, as mentioned earlier, who try to convert their gender identity rather than providing the care that the patient is presenting for in the first place. Trans and gender diverse people, therefore, often have very profound mistrust of clinicians at first, and clinicians may observe pronounced affective responses by trans and gender diverse patients to perceived slights, or in the context of clinicians who, say, haven't been trained to engage in sensitive and affirming communication with trans and gender diverse folks, misgendering people within care contexts, for example. And clinicians may be inclined to interpret these sorts of affective responses as possible borderline personality symptoms and interpersonal reactivity in the context of BPD, without necessarily understanding the underlying contextual factors. And if care settings, whether in the mental health space or otherwise, are designed to be inclusive and affirming of trans and gender diverse people, clinicians will typically find that these sorts of marked affective responses may not occur or may be significantly attenuated by these sorts of culturally responsive care environments. The clinical presentation generally of borderline personality disorder among trans and gender diverse people, and in the general population among cisgender people, may be similar. And certainly, there are going to be trans and gender diverse people with BPD, where there are, in all communities and in all populations. But the factors driving BPD symptoms among trans and gender diverse people may stem from this sort of chronic developmental gender minority stress experience. And the therapeutic approach, therefore, will generally need to address minority stressors and should occur within the kind of inclusive and affirming healthcare environment that I was mentioning. Clinicians who are new to gender-affirming care, whether it's mental health care or other care, and are treating patients with BPD, will often ask us whether a patient's gender dysphoria or gender minority identity is somehow a manifestation of identity diffusion or unstable identity. And clinicians will often wonder if a patient with BPD began identifying as transgender or gender diverse in response to engaging with other trans and gender diverse people, say within treatment settings. We've heard this from our residential treatment settings, the staff who work there at McLean Hospital, for example. And there was a paper that came out, I guess, 3 years ago from a researcher at Brown who coined this term rapid onset gender dysphoria and published this study that ended up being widely critiqued and discredited afterwards. It turns out that she only engaged parents of trans and gender diverse youth in the study rather than the youth themselves. Certainly, your child's gender dysphoria may be rapid onset news to you, but it doesn't mean that it's a new experience for them. And if a patient asks about gender-affirming medical or surgical care in this context for people who don't yet have a lot of experience serving this population, clinicians may worry that a patient's underlying motivation is to gain attention in some way. We've certainly heard this from mental health care teams, to disrupt pre-existing treatment goals, that it's a form of acting out in some way, rather than focusing primarily on trying to affirm the patient's gender identity. And then there's this question of whether or not to support initiation of gender-affirming medical and surgical care. Now, the standard for this and what standards of care call for is that the patient needs to have medical decision-making capacity to provide informed consent for care. Beyond that, our field has a sordid history of unnecessary onerous gatekeeping, questioning whether this person is in fact transgender or gender diverse, and delaying or creating various barriers to flat out denying access to gender-affirming medical and surgical care. It's really important to elicit a careful history of gender identity development to assess if the patient's disclosed gender identity has been persistent for 6 months. As it happens, DSM-5 diagnostic criteria for gender dysphoria include a persistence requirement of at least 6 months, and the World Professional Association for Transgender Health Standards of Care also have this persistence recommendation. And we can engage in what's referred to as gender identity exploratory therapy. Although gender identity for many trans and gender diverse people may be stable, some go through periods of questioning. In fact, many go through periods of questioning. And rather than this being a sign of identity diffusion and fulfills the criterion for BPD, questioning one's gender identity is often and typically the exact opposite. It's a process of clarifying and gaining comfort with your gender identity despite societal pressures to the contrary. So it's, in fact, the process of gender identity clarification and solidification. Patients may benefit from experimenting with different gender identity labels, gender identity expressions. Clinicians can really support patients in their journey of self-discovery by using a gender exploratory approach to psychotherapy. And is that right? Okay. Okay, great, thank you. And patients can be supported in pursuing potentially reversible forms of gender affirmation, like change in name, pronouns, style of dress, for example. Gender fluidity is how most people feel comfortable. It's not necessarily the case that everybody's gender identity or expression is going to settle on one particular state, and gender fluidity over time can often get misinterpreted as some sort of gender identity diffusion. It's in fact quite comfortably where many people live in terms of their identity and expression. It's important to understand that when people seek gender-affirming medical and surgical care, we want to initiate this based on an informed consent model. And if the patient has capacity to provide this, we really want to ensure that we're doing everything possible to move this sort of care forward. This is a paper we published 3 weeks ago in JAMA Surgery, again using the US Trans Survey. And we found a couple of things. One is that most people who desire gender-affirming surgery don't access it. It's a minority of people who desire these various surgeries who are able to get them. We also found, comparing people who desired gender-affirming surgery and accessed it to people who desired the surgery and weren't able to access it, that people who had surgery had lower odds of suicidal ideation in the past year cigarette smoking, and past month psychological distress. When we looked at degree of surgical gender affirmation, people who had just some of the surgeries they desired versus all, people who had all the surgeries they desired had lower odds of past year suicide attempts, past year suicidal ideation, past year smoking, past month binge alcohol use, and past month psychological distress. So we really want to minimize this sort of gatekeeping reflex that we have. And important to note that detransitioning, so deciding at some point that you no longer are transgender and going back to identifying as cisgender, is extremely rare. We published a study on this just in March of this year, and other studies show this as well. And among people who do go back to identifying as cisgender, regret of having undergone gender affirmation, including medical gender affirmation, is extremely uncommon. People view it as part of their gender journey and how they clarified and came to terms with what their gender identity is. Most of the factors driving detransition are also external factors like societal pressure, incarceration, moving, no longer having access to gender-affirming medical care, and the like. I'll just end by saying it's very important for us to think about how we can use the gender minority stress framework to culturally tailor evidence-based practice for BPD for our trans and gender diverse patients who have BPD. So for example, taking dialectical behavioral therapy, mentalization-based therapy, and infusing this with a gender minority stress lens and a gender affirming lens as we provide care. Here are some basic principles of how we can do this: normalizing the adverse impact of gender minority stress, facilitating emotional awareness, regulation, and self-acceptance, empowering assertive communication in healthcare and in life, restructuring some of the minority stress cognitions that I mentioned, validating unique strengths of trans and gender diverse people, fostering supportive relationships and community with other trans and gender diverse folks, and affirming healthy, rewarding expressions of gender. These are guidelines from John Pachenkis, who's based at Yale. And when we think about this, there are also new interventions being developed for trans and gender diverse patients, NIH-funded evidence-based interventions that are based on a minority stress framework and get at a lot of the manifestations that we often think about in BPD as well, resulting from developmentally chronically invalidating environments. So with that, I will stop and say that you're welcome to contact us anytime. We really advocate for care environments that are going to be inclusive and affirming in these ways. And addressing implicit bias among clinicians, we're happy to work with you all and your care teams to do that sort of training and think about how you can create care environments and mental health workforce that's going to be responsive to the minority stress needs and affirming of transgender and gender diverse people.
Wow. Thank you so much, Dr. Kuroglian. We have all learned a tremendous amount from you today. I'm thinking both as a clinician and as a researcher, how much I'm going to take from your talk and how I'm going to be able to help my patients in a more affirming way. Thank you so much. We have a ton of questions coming in from the audience. One that I want to ask you to take a look at here is: you had discussed understanding traits like impulsivity and rejection sensitivity as very reasonable, understandable reactions to the stigma that's experienced by being part of the marginalized community. And then you kind of contrasted that with having those same behaviors, impulsivity, rejection sensitivity, in BPD. Can you just help us understand this a little bit more? Very reasonable reaction on the, in the context of minority stress, slightly different in the context of BPD. Disentangle this for us, will you?
Sure. I think with regard to impulsivity, what I said is that certain behaviors may get interpreted as impulsivity when in fact they don't involve impulsivity if probed more closely. With regard to rejection sensitivity, certainly if someone is being, harassed every time they take the subway, just based on their identity, is being denied care, which we see reported by 33% of trans and gender diverse people based on their gender identity or expression. It is a reasonable response that I think any of us would have to expect rejection and be sensitive to it, rather than that being some kind of misinterpretation, shall we say, of a particular context, which is, for example, what we're taught to work on in mentalization-based therapy for BPD, which is a modality I was trained in. So I think it's not necessarily that someone is being overly sensitive or overly reactive, or that there's an attachment problem of the kind that we often think about in BPD based on how you formulate borderline personality disorder. It's as a result of very real and present threats, danger, abuse that people are experiencing in most facets of their lives on an almost daily basis.
Mm-hmm. Must be so painful and so difficult. Thanks for helping with that.
Dr. Kuroglian, I have, a comment and then a question. I want to say to you that so many comments are coming from the audience, and I am so thankful. One person actually said that they are literally sobbing as they were listening to your presentation.
I'm sorry I made someone sob.
Well, people do sob with relief. Yeah. And remembering that we have many clients and their family members in the audience, it's wonderful to read all those comments. from a, I guess, cis-privileged place of not having had to think of gender and sexual orientation for many years of my life, I can really understand the question that is asked, and I would like to relay it to you. Is this a new phenomenon where people are exploring their gender identity and their expression? And if so, why? Why in some cultures is this encouraged and discouraged? And what is the difference between gender dysphoria and being known as a tomboy? So a lot of questions to better understand all of this.
Great questions. As I mentioned briefly at the beginning, gender diversity has existed across history and across civilizations. I have a friend who's a historian who published a book a year or two ago called Female Husbands about 19th century extensively documented prevalence of people assigned female sex at birth who lived as men, were married, and were basically undercover in this regard. Gender diversity has existed in ancient times. Different cultures across the globe make relatively more or less room for gender diversity. In indigenous communities here in what we call the Americas, there are two-spirit communities and variations on gender diversity that have existed for centuries. In India, there has always been, there's the Hijra community of transgender women who we actually do very close work with now and are a historically accepted part of Indian culture, for example. It's now in modern Western society that we are, relative to where we were a few years ago, finally making more room for the naturally existing diversity in gender that exists among people. And a little earlier than that, we started making room in modern Western society for sexual minority people, for diversity in terms of sexual orientation, which we also know is something that has existed throughout history in all societies and still exists in all countries and in all societies. It's the extent to which the culture represses these naturally existing aspects of human nature, and or the extent to which we make room for these and have healthcare systems that are responsive to diversity in terms of sexual orientation and gender identity, have policies and laws that are inclusive of and protective of people with diverse sexual orientations and gender identities. So this is something that is there whether we acknowledge it or not, whether we are responsive to it or not, and whether we educate ourselves about it and become skilled affirming clinicians, or whether we choose to not do this. So the choice is ours as clinicians and people who serve communities in need. I think there was a second part to the question that I may not have answered.
I think we're at time, but we can certainly bring up more of this during the panel. Thank you so much for this enlightening and important answer. I very much appreciate it. And thank you for your presentation.
My pleasure. Thank you for having me.
So we hope that you guys have all enjoyed this fascinating morning as much as we have. We now have an hour-long break. We encourage you during this time to engage in self-care and to enjoy our exhibition hall, where you are going to learn about our sponsors and our exhibitors' programs that can be so helpful for your clients and for the families of your clients. The rooms are going to appear under the conference screen, and you are welcome to stop by any and all of them. And we'll see you in an hour at 1:35 Eastern Time to hear the lived experience of two sisters, Nama and Bria Paley. So we'll see you in an hour. Have a nice break.